This is a brief preview of the lecture video on the topic third trimester scan or the growth scan technique and protocols. This is only a preview and the main lecture is available on the site sonoshare.in. Short snippets of the various parts of the lecture video will follow. Having gone through the preview, if you wish to listen to the main lecture video, go to sonoshare.in. Third trimester is period from 28 weeks to after 36 weeks for better diagnosis of late onset FGR. This will be discussed in FGR chapter. Now, indicated third trimester scan can be for follow-up of a growth problem or a follow-up of a anomaly seen on the second trimester scan, or placental location or a placental pathology is available and already gestational age has been assigned. So, you have to put on report how gestational age has been assigned. If assigned by LMP or biometry in the third trimester, then the error range is plus or minus 21 days. So, the error is very high. Now, we have seen femur length can be small and then we must think of skeletal dysplasia. If it is long, it can be Marfan syndrome. Abdominal circumference can be small in diaphragmatic hernia or large in organomegalis or macrosomia. Then you have to plot the growth curve charts. So, growth curve charts, this is an example for the estimated fetal weight. They show trend automatically. If same machine is used for all the scans, then the same patient ID is selected for all visits. So, if you select that way, then the machine itself will show the all the plots and the trend automatically. So, that is the advantage. Then we come to the anatomy survey for anomalies. So, to pick up either missed anomalies, evolving anomalies or occurred anomalies. Anomalies on growth scan to a vascular insult. So, vascular insult has occurred prior to the anomaly scan, but it takes time for the atresia to become complete, obstruction to become complete, and the fetal swallowing to establish, and lesion can increase over time. So, manifest later when it is easier to pick up, or fetal size itself is increasing. So, as a result the anomaly may be seen better later, like VST. And then, so this is some examples of late manifestation we will see. Typical example is a non-lethal skeletal dysplasia of like achondroplasia. So, here you see anomaly scan, it is above 5th percentile, but then it falls below the 5th. So, duodenal obstruction needs swallowing of amniotic fluid to see the double bubble sign, or it may be due to a partial obstruction to the duodenum like a malrotation as seen here. This is again now all the conditions are described in their in detail in their respective system lectures. These are some examples to show or polyhydramnios. Now, here you see a case of lipomyelomeningocele where the cranial signs are absent because it is a closed defect, but you see the spina bifida, you see fat in the spinal canal seen in the axial scan and the sagittal scan and the coronal scan, a case which were picked up on the second trimester scan, and follow up for progression, complication or sequela. Now, here at 20 weeks the diagnosis of hydronephrosis due to PUG obstruction has been made, and a high frequency scan shows peripheral cysts and an echogenic parenchyma. So, on follow up at 34 weeks you see the kidney has become typical multicystic dysplastic kidney. with multiple non-communicating cysts and no parenchyma, and postnatal scan also confirms in the occipital lobe of both cerebral hemispheres. So when you follow that up, it results in bilateral porencephaly because of the atrophy of the overlying parenchyma. So this is sequel either hemorrhage or torsion as shown here. This is the echogenic, previously cystic mass, now it has become echogenic, and but blood supply is there. It's indicating that it is hemorrhage. It has leaked and produced ascites. So hemorrhage into ovarian cyst. Aspects of placenta which are to be looked for, and we know the technique and what are the pointers. One is the location. Now, if you see a low-lying placenta in the anomaly scan, we don't diagnose placenta previa, so scan has to be repeated due to velamentous insertion is shown. Here you see the velamentous insertion, and then you see the vessels crossing the internal os, causing vasa previa. Then next parameter is the amniotic fluid volume, which is assessed subjectively or by amniotic fluid index or by a single venosus, and the usefulness of color Doppler of these vessels is in FGR, which is described in a separate lecture. Thank you very much for your patient listening.